Глубоко уважаемые коллеги, добрый день. Для меня большая честь и не меньшее удовольствие открыть сегодня сессию «Персонализированная терапия пациентов высокого риска», которая представляет собой серию международных лекций в рамках деятельности научного центра мирового уровня, Центр персонализированной медицины. Этот статус теперь присвоен Центру Алмазова. Язык нашей сессии будет английский. И синхронного перевода не будет. Я полагаю, что это будет хорошим дополнением к образовательной ценности нашего сегодняшнего мероприятия. Мне очень приятно представить сопредседателя этой сессии, который не мог, к сожалению, по объективным причинам выйти сейчас с нами на онлайн-связь, профессора Альберика Катапана, это профессор Миланского университета и одновременно приглашенный профессор, работающий в стенах Центра Алмазова. И я представлю себя. Меня зовут Александр Олегович, моя фамилия Недашивин, я ученый-секретарь Центра Алмазова. У нас сегодня, надо сказать, звездная сессия абсолютно, потому что 4 лектора представляют ведущих европейских ученых в области кардиологии, визуализации, атеросклероза. И достаточно сказать, что 3 из них – это один действующий и 2 бывших президентов крупнейших европейских ассоциаций. С первым докладом выступит профессор Альберика Катапана. Доклады идут в записи. И этот доклад имеет очень интригующее название «Холестерин липопротеинов низкой плотности. От риска к причинно-следственной связи сердечно-сосудистых заболеваний». Итак, профессор Альберика Катапана, Италия.
Good morning, everyone. Today, my task will be to talk about LDL from risk to causality in cardiovascular diseases. These are my declaration of interest. Now, let's start with the LDL. What is the reason why LDL is causal in cardiovascular disease? LDL, indeed, has a coalescence of evidence pointed to the fact that it is causal to disease. It goes from epidemiology to intervention trials, to pathology and experimental studies, to genomics and genetics. All of them concur in posing LDL as a causal risk in atherosclerosis. Let me review with you briefly the evidence that has been gathered. Now, this data coming from the emerging risk factor collaboration, as you can see here, there is a clear correlation between non-HDL cholesterol, which is essentially the LDL cholesterol in cardiovascular diseases, while there is an inverse relation for HDL. So from the epidemiology from these kind of studies, and others as well that I'm depicting here, again, the non-HDL cholesterol, not only for cardiovascular disease, but also for ischemic stroke, you can see there is a correlation. Now, some people have maintained that age attenuates relation of cardiovascular mortality with cholesterol. It is true. Well, in relative term, yes. If you look at the relative risk reduction conferred by LDL, by a change of 1 millimole. However, look at the numbers. Here, the number of people having a relatively low cholesterol at the age of 80 has a number of events that is reported here, the hazard ratio. And they go from 128 about to 246, so it's twice as much the risk. And that's why people say it's attenuated, because if you look at younger people, they go from 1 to 8. This is 8 times more. However, the actual number is from 128 to 246. So it's 128 mostly. Here is from 1 to 8. Just to say that many people will die of cardiovascular disease. The relative risk is less, but the absolute numbers are still very high, even at old ages. Are other factors involved, LDL or non-HDL, ApoB1, ApoB? Well, these are data coming from studies and demonstrating quite clearly that HDL cholesterol and as well ApoA1, they perform reasonably good together, while the non-HDL and ApoB as well, they perform well. So there is no reason to withhold the concept that LDL is causal. The non-HDL and the ApoB will inform us a little bit more, but LDL is related strongly to cardiovascular events. Why so? Because there is a clear evidence that LDL are able to infiltrate with the endothelium, get into the arterial wall, and once there, start a number of events. But the point is they have to be retained. If they're not retained and can flux back and forth, almost nothing happens. But retention is important, and once they are retained here, they start a number of events, including the fact that they attract lymphomonocytes, they attract other cells of the immune system, start inflammation, that reiterates the damage at the arterial wall and eventually ends up in form cell lesions. We also know that LDL is linked to the size of coronary lesions. These are the numbers coming with IVUS. So you can see quite well that if you have higher LDL, even on a trial on a placebo or going down with treatment, there is almost a threshold by which you see that the plaque is changing. It's changing both in terms of volume, but importantly, even more importantly, in terms of composition, while the inflammatory component, the core, is getting reduced quite significantly the lower the LDL is achieved. Measuring LDL as a risk factor is also important because the concept has been how to determine that. Nowadays, we go with LDL cholesterol. This is good in many instances. However, when we change dramatically the composition of LDL, and that has happened, for instance, with CETP inhibitors, then there is a little bit of an issue there, and most probably would be important to have the ApoB determined. And this is the concept I was informing you with. Assessing ApoB may be better than assessing LDL cholesterol when you go to extremely low levels of LDL, because this is what drives the benefit. Evidence from genetic studies and intervention trials. Well, we know from genetics, and this is a paper we published with Brian Ferencz, that you put together all possible polymorphisms there that are bringing a reduction of LDL with their scores. You can see here the actual numbers. When you adjust that per 10 milligram deciliter of LDL cholesterol reduction, you get a decrease that is lifelong in the order of 18%. That's enough for 10 milligram deciliter, indicating therefore that the different mechanisms like cholesterol absorption here, or cholesterol production, or LDL receptor numbers, all of them concur the same way are reducing the effect. In other words, saying that the reduction of cholesterol is the driving force, not the mechanism by which we reduce cholesterol. And that has held the concept, and let's look only at the left-hand part of this slide, that if you have a lifetime higher exposure, like in subject with high LDL heterozygous FH, throughout life, you reach the event, the clinical event, much earlier than normal people. However, if you were to start with high intensity therapy, you will change the horizon for this subject, and you will change the progression of this curve into a curve that brings the people to a less difficult control of LDL and to a better outcome with time. You know, all primary and secondary trials have demonstrated without any doubt that by reducing LDL, you get a benefit. The benefit is proportional to the reduction of LDL, but is also proportional to the goal you have achieved. And that's why we have this effect here. And there is no threshold below which you start to be not effective. This has been shown further in the trials of Improving, Odyssey, and other trials that have been recently outlined. And if you explore the benefit there, you can see that even at very low LDL, you see essentially the same results. So this is important because, again, there is no threshold. It's not like glycemia, it's not like blood pressure. You can go as low as possible. You will still get an increment of the benefit. And this has also demonstrated, for example, this analysis of the Fourier trial, where you see quite easily that the decrease is continuous there, and even at very low levels of LDL, that's about 10 milligrams per deciliter, the curve doesn't change shape. And these are here the levels of LDL achieved in the control and in the treated group. What are the metabolic action of PCSK9 inhibitors? We know, and we have seen all over, and we have demonstrated quite well that there is a continuous efficacy of removal of lipoprotein. So they act to a removal of LDL. And this combination with statin is further increasing the removal of LDL, indicating therefore a mechanism that removes rapidly LDL is also of benefit. The consequence of a very low LDL level I've shown to you is beneficial, but also we know that we do not have any major issue unless we go to subjects with A-beta lipoproteinemia. These are the subjects who have an MTP deficiency, so are not able to build up ApoB, especially in the intestine. If we block completely in the intestine the absorption, we will have a problem because we don't absorb vitamin-soluble vitamins and we don't form chylomicron and we don't absorb fat. If we block the production in the liver, we may end up with lipid accumulation like triglyceride, but this is something that is overcome easily. Now, modeling the impact of LDL lowering coronary heart disease prevention. We have seen that randomized clinical trial give you results like this red line here, while on the top of this red line, there is the effect that is expected for a given LDL reduction with the genetic trials. Why this difference? Because the observation time is different and the area under the curve is completely different. In other words, for 1 millimole decrease, you decrease about 50%, 55% relative risk in genetic studies, lifelong, while you do much less with randomized clinical trials of 5 years. So what will be the concept here is the age and the accumulation. This slide just depicts for you this concept. In the normal person, in the people with polygenic hypercholesterolemia or with FH. You can see here the area under the curve becomes larger and larger, and this is bringing about the formation of lesion and the complexity of the lesion, getting to a complex plaque that eventually ruptures. Now, greater the relative reduction per milliliter reduction per plaque resolution, and then you have less when you go further down with age in treating at late stages, as we do now with drugs. However, any intervention will be beneficial because you will reduce the exposure to the lesion, to the damaging cause of disease, that is LDL. And as you can see here, there is a different opportunity which you can take advantage of with the LDL reduction. You can go from an eradication zone at early stages to a regression zone when you decrease further when people has already established lesions. You can stop, halt the disease with a similar intervention if you stay higher with the LDL. And the higher you go with the LDL, you get an accelerated progression of the lesion and accelerated atherosclerosis. So staying down here will enable you to reduce the impact and to keep an area that can be named as a eradication zone, if you wish, or regression zone, where you have an area where we tell the disease and the level around 170 to 100 milligrams per deciliter of the LDL. Above that, you will continue to build up the disease and get into the vascular events earlier stages. As you can see here, this is what happens for PCS loss of function people with always an LDL about 70, you stay there, while an FH, you are in this area, the yellow one, which brings a long and rapid progression of disease. At-risk people can be moved towards the atherosclerotic progression or stay in the eradication zone as you wish. We can go back and forth, depends on the intensity of the therapy we are ensuing. Targeting based on genetics is another important thing. There have been studies indicating that the genetic risk may concur in bringing the reduction of the benefit or increase the benefit. In other words, people higher genetic risk will benefit the most. This is not a surprise because they are at absolute risk that is higher from that of the rest of the people. So will genetic score help us to identify these people? We don't know for the time being yet. However, what is important is we have these tools now, and we can definitely experimentally use these tools in order to be able to better select and better target therapy to those who are at very high or exceptionally high risk. Let me just touch a point that we just published on the ApoB instead of LDL cholesterol. It's essentially the same thing. There is one ApoB per each LDL. And if you look at the genetics and make scores that are related to absolute lower plasma ApoB concentration, you can see the relation of to the risk is exactly the same in terms of perspective at that of the LDL, and is a strong relation depending on the absolute lower levels you have. Doesn't matter if you have a PCSK9 mutation or ApoC3, angiopoietin-like 4-3, HMG co-reductase. Doesn't matter. Whatever reduces LDL or non-HDL cholesterol, which is an ApoB reduction, will bring you this benefit as measured as ApoB changes. And then you run a multivariable Mendelian randomization, and what you see that the only thing that will survive is ApoB. LDL cholesterol and triglyceride will disappear. So ApoB is much better than LDL cholesterol and triglyceride at assessing risk, and will be potentially the best thing to target in order to homogenize the intervention. And if you run a meta-analysis of the trials, so lipid lowering for ApoB changes, you can see that you end up with the essentially similar correlation to that has been reported for the CTT meta-analysis for LDL absolute reduction. You can see here the absolute reduction of about 22 or 25 milligrams per deciliter of LDL will bring a reduction that is approximately the same as you have in the CTT for 1 millimole of LDL cholesterol reduction. So, in summary, LDL satisfies key criteria as a causative agent in atherosclerosis. Atherosclerosis regression induces even late intervention, but not reversible fully unless LDL lowering is early in adult life introduced. Very low LDL levels can be achieved with combination therapy to provide greater impact without apparently serious side effects. And more effective strategy-based primary prevention could be based in part on genetic scores in order to be able to address the population at early stages, reduce their cholesterol, and keep them well for their cardiovascular system, starting an early intervention. Thank you very much for your attention.
Поблагодарим профессора Катапана. Прекрасный доклад, просто о сложном. И основной тезис: чем раньше, тем лучше, и чем ниже, тем лучше в отношении снижения уровня холестерина, липопротеинов низкой плотности, был развернут блестяще экс-президентом Европейского общества по атеросклерозу. А теперь нынешний президент Европейского кардиологического общества, профессор Стефан Ахенбах, с докладом «Ишемическая болезнь сердца и исследование ишемии. Какие выводы следуют?»
Dear ladies and gentlemen, my name is Stefan Achenbach from Erlangen in Germany, and it's a pleasure for me to talk to you today about coronary artery disease and the ischemia trial, a very prominent trial that was recently published. What are the implications? Before going into the details of the trials, let's take a step back and take some very basic considerations. Question number one is, what do we want to know in patients with suspected coronary artery disease? Why do we do diagnostic? What do we want to find out? Well, the first question is, of course, when the patient reports symptoms, are these symptoms caused by ischemia? The second question is this patient at risk for future myocardial infarction and death? These are the two major questions that drive us when the patient reports with suspected coronary artery disease. But for the first question, a little bit more detail is, in addition, usually, can these symptoms potentially be relieved by revascularization? Should we move on to an invasive strategy? And for the second question, at risk for myocardial infarction and death, the question is, can this risk be reduced by revascularization on one hand, or by statins and aspirin on the other hand? So these are the diagnostic questions that drive us. As far as the symptoms question is concerned, and the question whether revascularization will be useful to reduce the symptoms, which is very important for the patients, usually we will be looking for coronary artery stenosis. But we all know that the presence of a stenosis by itself in this situation is often not enough, because not every stenosis causes ischemia. So usually, in order to know whether the patient's symptoms is caused by coronary artery disease and whether revascularization will be useful to relieve the symptoms, usually also necessary to have information about ischemia, either by non-invasive testing, here you can see in stress magnetic resonance, or invasively by measuring the FFR. The second question, does the patient have an increased risk for future events, myocardial infarction and death, is even more difficult to answer, because we all know that some patients might have almost normal looking coronary arteries, like this person who had an invasive angiogram. The left circumflex coronary artery looks pretty much normal, yet 4 days later, there is an acute coronary syndrome because of plaque rupture. This previously normal looking circumflex artery suddenly occludes. So in order to predict whether somebody has a risk for events, just looking at stenosis might not always be enough, because as our data shows, and as we know, about 70% of acute coronary syndromes and sudden death are caused by lesions which are not high grade. Less than 50% stenosis are underlying in 70% of the acute coronary syndromes. So for patients to identify those who are at increased risk, on one hand, of course, it's useful to know whether they have prognostically relevant stenosis, such as this left main coronary artery stenosis. This is definitely useful, but it might, in addition, it might be useful to also know about plaque in the coronary arteries, non-obstructive lesions. This is potentially also useful, because we know that these lesions are often the reason for acute coronary syndromes. The next question is, how accurate are our tests that we use in coronary artery disease? How accurate are they to find patients with coronary artery disease? And of course, there are numerous publications for all kinds of diagnostic tests looking at the accuracy. And here's just a very, very recent one from just a few weeks ago, looking at what is probably the best clinically available stress test, stress magnetic resonance perfusion imaging. And this comprehensive protocol by MR in patients with suspected coronary disease in 764 patients showed that late enhancement plus perfusion at stress and at rest had a sensitivity of about 80% and a specificity of 87% to identify high-grade, more than 70% coronary artery stenosis. In the recently published guidelines of the ESC on the management of chronic coronary syndromes, on the management of stable coronary artery disease, there's a summary that we can find about the published accuracies of our diagnostic tests. And here you can see that exercise EKG, of course, is not performing so well. Specificity is surprisingly high, but sensitivity is low. And for most of the other tests, mainly those which are really clinically available, SPECT, stress echo, stress MR, coronary CTA, we can see that the sensitivities are in the 75 to 96% range. The specificities are approximately in the 80% range. So if performed by experts in the best of circumstances, for our non-invasive tests, and we can disregard exercise EKG for now, for the non-invasive imaging tests, the sensitivity is about 90%, the specificity is about 80%. Taking all of this into account, what do we want to know in patients who have suspected coronary artery disease? How good are our tests? The ESC in 2019 has published an algorithm or advice on which tests to use. And it says that if the risk is very, very low, the symptoms are very atypical, the patient is young and has no risk factors, no diagnostic testing is needed. It will not contribute to our measurement. If the risk is very high, very typical symptoms, maybe changes in the resting EKG, maybe an abnormal echocardiogram, very high risk for coronary artery disease, it makes sense to go immediately to invasive angiography, provided that pressure wire measurements are available in the cath lab so that you can evaluate when you see a lesion whether it really causes stenosis. And for the large group of patients in between, you can either do testing for ischemia or coronary CTA. That's the advice of the ESC. And you should choose the test depending on patient characteristics, depending on what you have available, depending on what your particular expertise is, and also some other considerations. So basically, this is a different graph from the same guidelines. For a patient with suspected coronary artery disease, there are 3 different entry points into the diagnostic and management algorithm. It might be that patients are best treated by immediate invasive angiography, sometimes coronary CTA, sometimes non-invasive testing for ischemia is the best entry point. Invasive angiography, preferentially if the patient has a very high clinical likelihood and severe symptoms. Also, if the patient has left ventricular dysfunction that suggests coronary artery disease. Coronary CTA as the entry point, for example, in individuals who have a relatively low clinical likelihood, we want to rule out disease, and always, of course, if there's local expertise and availability of the respective technique. And then non-invasive testing for ischemia, preferentially if the pretest likelihood is relatively high, and also very important if you want additional information about viability, then non-invasive testing for ischemia, nuclear medicine, stress echo, or magnetic resonance are often the preferred option. Now, if a patient has one of these tests and an invasive angiography, a stenosis is found, stenosis with established correlation to ischemia, either because there has been a non-invasive stress test or because FFR was measured in the cath lab, then revascularization is recommended. Correlation to ischemia is not necessary if a stenosis is more than 90%, but a more than 90% stenosis is not very frequent. So basically what the ESC says is you need to see a stenosis in invasive angiography. You need to have a correlation to ischemia, either by non-invasive testing or by FFR, exception more than 90% stenosis. Then revascularization is indicated. Now this chain, non-invasive testing for ischemia, invasive angiography, and then revascularization. This is what was tested in the ischemia trial. Whether patients who have a non-invasive stress test that is positive indicates ischemia should really always go to invasive angiography with the aim of revascularization, or whether that is not always necessary. This is what the ischemia trial investigated. The ischemia trial was published in April 2020 in the New England Journal of Medicine. Not just one publication, there are several publications. But basically the test did the following. There were about 7,000 patients who had suspected coronary artery disease and a positive ischemia test. And the question, as I said, for the trial was, should these patients go to the cath lab for invasive angiography with the plan for revascularization? However, the ischemia trial applied a filter to these 6,836 patients who had suspected coronary artery disease and a positive stress test. The patients went to CT angiography first. CT angiography for 2 reasons. On one hand, the question was there left main stenosis? If CT demonstrated a left main stenosis, the patients were removed from the trial because it was considered too dangerous to randomize them to a non-angiography strategy, to randomize them to medical treatment alone. So patients with left main stenosis, there were 439 of them, were taken out of the trial and sent to invasive angiography. And on the other hand, CT angiography investigated the coronary arteries, and if all coronary arteries had no stenosis of more than 50%, basically if the coronary arteries were all non-obstructive, then the patients were also taken out of the trial. And this was the case in 1,200 patients. And this is approximately the 80% specificity that we have for ischemia testing. Not everybody in whom the ischemia test is positive really has coronary stenosis. So these patients without stenosis of more than 50% were also taken out of the trial. There remained 5,179 patients who had a positive stress test, no left main stenosis, and CT had not identified the absence of obstructive disease. These patients were randomized to an immediately invasive strategy. What we would clinically typically do, send the patients to invasive angiography, or to a strategy that was initially conservative, no invasive angiography, but maximum medical therapy, including high dose statins, maximum tolerated dose. The patients were then followed for a mean period of 3.3 years, some patients up to 5 years, and they were followed for death, stroke, and coronary artery disease events, myocardial infarction, unstable angina requiring revascularization. In the immediately invasive therapy, everybody in the immediately invasive arm, everybody had an invasive angiogram. Most of the patients then had a revascularization, 80% had a revascularization. In the initially conservative arm, no invasive angiography was performed at the beginning, but if the patient had ongoing chest pain or if the clinical decision was that an invasive angiogram is needed, then the patients were allowed to go later to invasive angiography as dictated by the clinical course. And it turned out that 23% of these patients in the course of the trial also received a revascularization. So this is the outcome. And of course, it was intended to find out whether an initial therapy, initially invasive strategy with revascularization in these patients with a positive stress test would reduce events, and did not. If you look at the combined outcome, cardiovascular death, myocardial infarction, unstable angina, heart failure, or cardiac arrest, there was no difference between the conservative arm, medical treatment, statins, high-dose statins, only angiography if clinically needed, and the routine invasive arm. No difference, no advantage of routine revascularization of these patients. And also, if you look at single endpoints, cardiovascular death, all-cause death, no difference, not in the one and also not in the other direction. Myocardial infarction, there were a few more early infarctions, mainly PCI-induced troponin increases in the revascularization arm, but over the course of time, you can see that spontaneous infarctions were somewhat less frequent in the invasive arm with 80% revascularization, and they were somewhat more frequent in the conservative arm. If you looked at spontaneous infarction alone, they were in fact significantly less frequent in the invasive arm after a period of 5 years. Now we do not only revascularize for prognosis, as I said initially, also, and for the patients, very important, for symptoms. Stent placement, revascularization by bypass surgery are very effective symptomatic treatments. So this was also investigated. Do the patient's symptoms get better? Now, in patients who had no angina as they went into the trial, about 30% of patients had no angina. Of course, the revascularization, the invasive strategy did not improve symptoms. You can see no change in the angina frequency in those patients who did not have angina at baseline. However, in those patients who had angina daily or weekly, there was a significant and substantial improvement of angina, self-reported angina, in the patients who underwent the invasive strategy with revascularization. So it turned out there was a significant decrease of angina, of symptoms in the invasive arm, better relief of symptoms in the invasive arm than in the initially conservative arm. So the summary of the trial would be that in patients with a positive test for ischemia and suspected coronary artery disease, positive test for ischemia and suspected coronary artery, but no left main stenosis, there is no improvement of the prognosis by an immediately invasive strategy as long as intensive medical therapy is given. But there's a pronounced improvement of symptoms if the patient had angina at baseline. So maybe surprising that revascularization did not improve prognosis. But then again, we have to be aware that for inclusion into the trial, any positive stress test and the presence of even just any one 50% lesion in the coronary artery tree was enough to be included in this trial. So maybe there was just, some circumflex branch with a 50% stenosis, and we can all imagine that revascularization of this branch will probably not improve the patient's prognosis. So I'm sure we will see sub-analysis that look at lesion type to identify those who really benefit from revascularization in the near future. Here's the editorial by Eugene Braunwald and Elliot Antman about the trial, and they basically say the same thing. They say that if there is strict adherence to guideline-based medical therapy, this is especially aspirin and high-dose statins, patients with stable ischemic heart disease who fit the profile of those in ischemia, no left main stenosis, and who do not have unacceptable levels of angina can be treated with an initially conservative strategy. So unless there is a lot of angina, an initially conservative strategy is reasonable or can be chosen. However, an invasive strategy which more effectively relieves symptoms of angina is a reasonable approach at any point in time for symptom relief. There was a sub-analysis. It was just published. It's only available online so far, looking at patients who have heart failure. About 400 of the patients in the trial had reduced left ventricular function. No patient was allowed to have an ejection fraction below 35%. So these are patients who have heart failure, but an ejection fraction of still more than 35%. And in these patients, there was a clear signal towards a reduced incidence of the combined endpoint if revascularization was performed. You can see here, patients without heart failure, no difference between the invasive or conservative strategy. But in patients with heart failure, the event rate significantly lower in the invasive strategy than in the conservative strategy. This is only a sub-analysis. It's retrospective. It's a small group. So it's only a signal that needs to be tested further. But it's interesting to see that in heart failure, this looks like there is a benefit of revascularization. In patients with suspected coronary artery disease, and positive ischemia test and a stenosis of at least 50%. So coming back to the original question, coronary artery disease and the ischemia trial, what are the implications? Well, the implications of this large trial, it took years to complete and included, as I said, initially 8,000 patients were screened, 6,000 patients were then underwent the testing, 5,000 patients were randomized, very large trial. The implications is that in patients who have coronary artery disease and positive ischemia tests, but no left main stenosis and no left ventricular dysfunction, we have a choice. A choice of either immediate catheterization and revascularization, which will effectively, very effectively relieve symptoms, even though we know that it probably does not improve the prognosis if we take all of the patients. Or we can also reasonably do an initial trial of intensive medical therapy alone, provided that there's aspirin and high-dose statin therapy. So it gives us the choice. We can make the choice together with the patient and also taking all of the information that we have about our patients into consideration. Revascularization is very effective for relieving angina, but for prognostic reasons, it's not always necessary to perform an invasive strategy. And with that, I thank you very much for your attention.
Прекрасный доклад, и вновь каждому из нас предстоит вот этот шаткий баланс между инвазивной стратегией, немедленной и оптимальной медикаментозной терапией выбирать самому. И основная идея все-таки заключается в том, что прогноз не улучшается у определенной категории больных без выраженного поражения коронарного русла и без дисфункции левого желудочка на фоне инвазивной стратегии, а качество жизни, конечно, существенно улучшается при выполнении реваскуляризации. Но, с другой стороны, это гимн оптимальной медикаментозной терапии с максимальными дозами статинов, аспирина, которые действительно позволяют прогноз иметь такой же, как если бы это была реваскуляризация. И изумительный анализ. И спасибо профессору Ахенбаху. Мы идем дальше по программе. Питер Керхоф, один из очень, я бы сказал, один из самых оригинальных умов в европейской кардиологической медицинской науке, с интригующим названием доклада «Открытие на пути из Москвы в Санкт-Петербург. Понимание сердечно-сосудистой системы без учета традиционных расчетных показателей». Итак.
Dear colleagues, my journey starts in Moscow and now presents my latest findings in St. Petersburg. First, congratulations for the celebration of 40 years and to the success of the meeting. 40 years ago, in 1980, I was working on ratio-based metrics and developing the working point concept that refers to volume, pressure, and flow. First, I will survey the fundamentals of cardiophysiology. Here you see pressure volume loops, the red one typically for women and the blue one for men. They're slightly different, as you may know. We can see end diastolic volume and systolic volume, the systolic elastance, the effective arterial elastance, and the ratio of the two elastances is the ventricular arterial coupling index. And then we have this mysterious V0 about which is little known, but to me it seems that it's very important. We are concentrating now on the working point. That means the combination of end-systolic volume and end-diastolic volume. Here you see a typical example of a number of diagnostic groups. And if we plot end-systolic volume versus end-diastolic volume as normalized for body surface area, then we see a fairly nice linear relationship. This linear relationship has two constants, alpha and beta, and they can be used to formulate a new relationship between ejection fraction and end-systolic volume. The analytical expression for that is given below, with two population-based constants, C1 and C2. It happened that in 1982, there was the World Congress in Moscow, and I was invited to join the Young Investigators competition. Here is the material I presented there. A linear, fairly linear relationship between ejection fraction and end-systolic volume. To the right, in the lower portion, we see that there is some flattening of the curve. So that is the asymptotic region. And the analytical expression that I showed before accounts for that non-linearity. Ejection fraction, I don't have to explain, is very commonly used in cardiology with more than 68,000 hits. But the question is, regarding this popularity, is it the index really informative, or rather a little bit misleading? There are other ratio-based metrics in cardiology, the fractional flow reserve, coronary flow reserve, and the augmentation index. I will talk about them later. I had, at the beginning of my career, a fundamental question. Why is ejection fraction important? And I brought this question to one of the cardiologists in training, and he told me it's because our professor tells us. But that was not a satisfactory answer for me. So I started thinking about ratios, and this area I will call ratiology. If we look at the definition formula for ejection fraction, then we see that it depends on the balance between end-systolic volume and end-diastolic volume. That's a very subtle balance, and the impact of the two components is not equal. The basic question is if the single number embodied by ejection fraction is able to tell us the same story as the two variables combined. And of course, this cannot be true. Here is an example where we see ejection fraction during a control meeting, and at follow-up, we see that the value for ejection fraction is exactly the same, but the underlying volume data are different. So that is an example of different situations leading to the same numerical value of the fraction. Schematically, we may ask what happens if you have a variable x and a variable y, and you put them together, and with some data processing. In this case, we take the ratio y over x. We start with two numbers and end up with one single number. So we ask, what is neglected? What information is left out? Where is it gone? What does it mean? Here we again have the volume domain representation, end-systolic volume versus end-diastolic volume. And on the line for ejection fraction 50%, I have indicated several red dots. These are individual working points, so they are combinations of the two volumes. And while the ejection fraction is the same for all these working points, their distance from the origin is different. And we can calculate that distance by using the Pythagoras theorem, and that yields the information that was missing. The volume domain representation is really convenient because we can depict several diagnostic groups. Here again, the red line where ejection fraction is 50%. Below that line, all the data points that are represented here have an ejection fraction above 50%. For example, this triangle, we will find a heart failure with preserved ejection fraction group. For those in this area where the green arrow is shown, the ejection fraction is less than 40%. And for the triangle in between, we have the gray zone, which we nowadays call the mid-range ejection fraction. This is to the left the picture that we have seen before, but now to the right, for the same data, I have shown the relationship between ejection fraction and systolic volume. And you see, although not linear, this is a mathematically a very convenient expression. Similar to the left for biplane angio data, all heart failure patients, stratified for men and women. And to the right, and this is the important point, now we see ejection fraction versus the hypotenuse. So this is the companion metric to ejection fraction. And we see that if we select a narrow range of ejection fraction, that there is a certain spread of data for the companion metric. And it's even worse if you go to the lower ejection fraction range, then we have a very wide differentiation of the hypotenuse values that should be taken into account. I have been telling this story, of course, a number of times at different places on the world. I remember one in New York with Professor Sonnenblick. And there are very interesting questions to bring up just by looking at ejection fraction and systolic volume. Here we see for Europeans and for East and South Asian groups, men and women, we see they are located in different areas in this diagram. However, we should realize that the scale to the left is very compressed. And if we expand it as shown to the right, then we see that at least two of these groups simply form a nonlinear relationship as predicted before. I also analyzed data from Almasov Center, and here you see ejection fraction for 4 groups of patients with inflammatory diseases versus the companion metric that complements the ratio-based metric. And here you see again, if you select a certain value of ejection fraction, then there is a very wide spread of data that refer to the companion. Thus far, the volume domain. Now we turn to the pressure domain. And if we plot similarly diastolic arterial pressure versus systolic pressure, and this is the identity line, then the green arrows indicate the pulse pressure. And for patient E and patient B, we see that the pulse pressure is the same. However, the question is, if the companion metric is similar. No, it's not. This can again be derived from the length from the origin to each individual point using the similar Pythagoras formula as shown before. This is an example where we see the pulse pressure versus the companion, and again for any particular value of PP we see a very wide range of data for the hypotenuse. Finally, we address the flow domain, and these are Doppler signals during baseline and to the right during adenosine. And well, we get the familiar representation now of the flow, the hyperemic flow versus the baseline flow. There is a certain working point. The slope of this arrow indicates the ratio of the two. That's the coronary flow reserve, and the distance, that's the companion that is required to fully describe the situation. Here's an example taken from the literature. We have our own data, but they will be published soon. So now I refer to the literature. The coronary flow reserve companion versus the original ratio, and again we see a spread of data points. So just the ratio is insufficient to personally describe each individual patient. And summary, going from 1980 with the working point concept to the ratio-based metrics and their companion now, we may ask the question, what is important, ejection fraction or end-systolic volume? First, we thought that end-systolic volume is important because it nicely relates to ejection fraction. But now it becomes clear that the interpretation should probably be the reverse. Ejection fraction is maybe important because end-systolic volume is important. And then we have the issue of the missing component. I have schematically shown that again in the lower left portion. If from your home during a bright night, you look at the sky and you see the moon, and in the same direction you see a star, then you know that although the direction is the same, the distance is fundamentally different. And you have to account for the distance in order to locate each of the celestial bodies. Finally, the companion is easily calculated and you do not need any additional measurements. And for the future, we want to evaluate alternatives for the companion that may be even better suited. We will do machine learning approaches to cluster diagnostic and genotypic groups. We want to perform survival and MACE studies to compare the two components, and we want to elaborate on ethnic and age and sex specific issues. Of course, this is not just my own work. I had nice discussions with many colleagues from all over the world, and I thank you for your attention.
Прекрасный доклад, коллеги. С одной стороны, последним своим заключительным слайдом, обращающий нас в истинное будущее того, что называется персонализированная медицина. Вот все пункты перечисленные относятся именно к будущему персонификации медицины и одновременно с очень полезным экскурсом для каждого из нас в физиологию кровообращения. Мы так часто используем термины фракции выброса, конечный диастолический объем, что, к сожалению, иногда упускаем сущностную сторону этих понятий. Мы ориентируемся на некоторые цифры и говорим, фракция выброса выросла, фракция выброса снизилась. А вот этот возврат нас всех, как мне кажется, к истокам физиологии кровообращения, ну, если хотите, даже к закону Франка Старлинга, про который, к сожалению, многие наши коллеги уже забыли, и вот эти соотношения сила, сокращение объем камеры сердца, они звучат очень современно, хотя кажется, что все это давно уже не так важно. Итак, следующий доклад. Экс-президент Европейского кардиологического общества, профессор Ероен Бакс, один из ведущих специалистов в области визуализации в мире, работающий в Лейденском университете, с докладом «Оценка пациентов с сердечной недостаточностью для выбора ресинхронизирующей терапии». Профессор Бакс.
Hello, everyone. It's a pleasure to be virtually with you in the Almazov Center. It has always been a pleasure to be with you, but now the times have changed a little bit. So we're going to talk today about cardiac resynchronization therapy in heart failure. And let's keep up the good spirits and not become depressed, okay? So here we go. If we look at the CARE-HF trial, which was one of the first trials that compared cardiac resynchronization therapy with medical therapy, the orange bar is medical therapy alone. The blue bar is medical therapy plus cardiac resynchronization therapy. And this was actually the main trial why cardiac resynchronization therapy was included in the guidelines. You see that the orange bar is each time higher. So the primary endpoint and all-cause mortality was higher. Medical therapy was clearly inferior to cardiac resynchronization therapy on top of optimized medical therapy. But when we look at the individual patients, and that is almost every therapy that we do, we have responders and non-responders. So how do we define a response actually? Well, the markers of chronic response, we defined it as clinical parameters as 6 months of follow-up that are New York class, quality of life score, 6 minutes walking distance, exercise capacity, or you can do peak VO2. In the daily practice, we work mostly with New York class or quality of life score, or 6 minutes walk distance. We also have echo parameters. What is your heart doing? Is your left ventricular ejection fraction increasing? Are your left ventricular dimensions and volumes getting smaller? Are you taking away, reducing the mitral regurgitation? And are you getting, because of CRT, left ventricular resynchronization? These are echo parameters that have been used in studies. If we look at clinical versus echo response, if we look first at the picture on the left, 96% echo non-response, and the same is more or less for clinical non-response. So of all the clinical non-responders, 96% of those have also echo non-response. Let's take a look now at the right part. Here we got, again, clinical response, but out of the clinical response, we got 24% echo non-response. That means that if I don't feel better, my echo is also not improving. But if I feel better, in about a quarter, 24% of those patients do not improve in echo response. What do I mean with echo response? An improvement of ejection fraction, a reduction of volumes. So then the question comes, should we get rid of all this and just focus on survival and not speak about clinical response, non-response? This is New York class, feeling better, not feeling better, echo response, non-response, smaller volumes, bigger volumes. Should we just say, let's take one endpoint, and that is survival? Based on that, selection criteria for CRT as they stand still now is New York heart failure class 2 to 4. Initially, we had only 3 to 4, but then also studies showed that you also have a benefit in class 2. An ejection fraction, let's say between 30 and 35%, a QRS more than 130 milliseconds with a left bundle branch block configuration. These are the ideal candidates. Even if we take those ideal candidates and you look at an individual level, we see that the non-response rate is still 30 to 40% at 6 months. So the response to CRT, we ask ourselves, what should we do? Should we look at cardiac dysynchrony? And if we do, which dysynchrony? Should we look at interventricular dysynchrony? That means the right ventricle versus the left ventricle. Or should we look at intraventricular dysynchrony? That is the septum usually versus the lateral wall. So it's within the left ventricle. Or should we look at atrioventricular dysynchrony, the atrium versus the ventricle? If we look at the literature, this was published in 2005 when CRT was really coming big time. When we looked at the literature and we ask ourselves the questions, what is the most important factor? Is it intra or interventricular dysynchrony? There were by then 24 studies on prediction of response to CRT. 2 of those demonstrated some value of interventricular dysynchrony, means the left ventricle versus the right ventricle. And 24 demonstrated some value of intraventricular dysynchrony. So all these papers showed that based on the synchrony in the left ventricle, which is mostly the septum versus the lateral wall, is an important predictor of response. How do we measure this LV dysynchrony? Which echo technique do we need to take? Well, the most simple one is an M mode. Here you see such an M mode. And you see actually in this M mode, here is the septum, and this is the posterior wall. And you see that this septum comes quite early and the posterior wall comes quite late. So there is significant delay between the septum contractility and the posterior wall contractility. If they use this criterion as a predictor for response, they found 100% sensitivity and a 63% specificity. That is not ideal. So we're looking for new things. So we started to work with this tissue Doppler. Here you see a picture of the tissue Doppler. The color codes are the early and the late movements. So this is movement, tissue movement. And this is the septum, and this is the lateral or posterior wall. If you just take a look at a normal individual, these are the patterns that we see. E and A, E and A. These are the diastolic velocities. And in between, there are the peak systolic velocities, right? So peak systolic velocity, diastolic velocities, peak systolic velocity, diastolic velocities, and so on. Now we're interested not so much in the diastolic velocities, but we're interested in the peak systolic velocity. This is a tissue Doppler where you sample the septum and you sample the lateral wall. The green is the lateral wall, the yellow is the septum. We see here actually that both the lateral wall and the septum have a same peak systolic velocity, and so there is no dysynchrony. The green and the yellow are taking place exactly at the same time. This is a very dysynchronous heart. I have an early septum and I have a very late lateral wall. So this is significant left ventricular dysynchrony. Let's take a look how these things now work. So we looked at predictors of response to CRT in the PROSPECT study. This was a retrospective analysis of a big cohort of patients, 426 patients, 71% was male, mean age was 68 plus or minus 11 years. You see here that there was almost 50-50% non-ischemic and ischemic cardiomyopathies. The ejection fraction was low, 24%. The vast majority of patients was in New York class 3. This was at the time that only New York class 3 and 4 were okay for CRT. Now we know that in New York class 2 it's also okay. They had a wide QRS because you see a duration of 163 milliseconds. And now if we look at the clinical and the echo response, we see that what we already discussed before, 70% has a clinical response, but the echo response is much lower, only 50%. So these are the different measures that we did. We basically assessed all the possibilities that there are. So we looked at interventricular dysynchrony, and we did that with pulse Doppler, QRS to onset on pulse Doppler in the aortic versus the pulmonary outflow tract. What does that mean? That means actually the aortic is the left ventricle and the pulmonary outflow is the right ventricle. So this is a way to assess the synchrony between left and right ventricle, interventricular dysynchrony. And then we looked at the left ventricular dysynchrony, and we did it by M mode, that same method that you just saw. We did it by tissue Doppler with 2 segments. We did it by tissue Doppler with 6 segments. And what we saw, and here you see sensitivities and specificities. In yellow is cutoff criteria met, in blue is cutoff criteria not met. Sensitivities and specificities are reaching maximum, let's say less than 70%, to predict a reduction in left ventricular and systolic volume. So these are not ideal. And here you see these things. We got the tissue Doppler, we got all sorts of measurements that we tried, but none of them gave us 100% sensitivity and 100% specificity. So why this failure to predict? Well, up to 30% of the data in that study could not be analyzed. In other words, by then, the quality of the echoes was rather poor. So that actually resulted in a lot of patients not being analyzable. The inter-observer variability was 30%. And this was assessed only on 10 patients, so this is really not good. Intra-observer variability was 10%. So why all these problems? Well, let's take a look what causes actually heart failure. This is a compilation of 20,000 patients in all the major heart failure trials. And we see that the vast majority of patients, almost 70%, has underlying coronary disease, and 30% has non-coronary disease. So this is all ischemic cardiomyopathy, and this is non-ischemic cardiomyopathy, if you like. Well, if you go back to your clinic and you look at your heart failure patients, the vast majority is coronary artery disease related, right? So if we do this septum to posterior wall ratio, in a non-ischemic cardiomyopathy, we can assess this quite well. Here you see a septum, and here you see this posterior wall, and you can see actually the excursions fairly well. But this one, as you see already, is very hard to see. So posterior wall often in the images that we take does not have a good image quality. And if we look then at ischemic cardiomyopathies, it gets even worse. This one has an anterior infarction, so there's no septal excursion at all, and I still don't see anything on the posterior wall. So ischemic cardiomyopathy, which is the majority of the patients that we look at, the septum to lateral wall assessment is difficult. In one study here, 72% ischemic cardiomyopathies, more than 50% uninterpretable. Here is about 60% cardiomyopathies with 40% uninterpretable. So this builds the case that the patients with ischemic, but also partially non-ischemic, are hard to interpret with this method. So we need something better. So we went to this tissue Doppler. But if you look at the tissue Doppler, here I see my septal curve. This is the yellow, you see the septal curve. But in the green, I see no excursion at all. And that is because you have a big infarct there. So as soon as you got a big infarct, there's no more excursion, or it's passive motion at best. So what about if we get flat lines like this? Then I can assess the septal, but I cannot do the delay on the lateral wall. And you also have this, where you see multiple peaks. If you look at that septum here in yellow, he has one peak and two peaks. So multiple peaks, which makes it difficult. So why the failure to predict? Well, another reason on top of these technical reasons is that 30% of the patients had a relatively high ejection fraction, between 30 and 50%. These are not the patients that we want to look at. More than 30% of the patients had an LV end diastolic dimension less than 60 millimeters. So these are not dilated hearts. So we have technical problems and we have clinical problems, because the clinical problems that we have looked at here is not really the CRT population. I'm watching a little bit the time. So are we then back to the ECG? Are we just going to do ECG? No, because you see here that if we look at, on the x-axis, the baseline ECG, and we have the sensitivities and specificities on the y-axis, if we look the optimum for both is the cutoff, you get at best a sensitivity and specificity of 50%. So this is not what we want. So wider QRS will always respond to CRT. Is that it? No, also not, because here we see all sorts of QRS durations from 120 to 140, 140, 160, 160, 180, 180, 200, more than 200. And you see in all of those that there is clinical response, but all of those have about 30% non-clinical response. So just taking the very wide QRS is not the solution. That's not going to bring us the solution. So we need more precise imaging techniques. And so we can use echo, and we use 3D tissue synchronization imaging, and we can do real-time 3D echo, and we can also switch to strain, and eventually we can think about MRI. So this is this tissue synchronization imaging, and you see it here in 3-dimensional. So these are the echo images that you take, and from these 2, 4, and 3-chamber views, you comprise this 3D picture, and you see here in orange the latest activation. So this is the posterolateral wall, basically where normally the latest activation is in dilated cardiomyopathies. So this is a way of looking at where is my latest activation. So the standard is the septum, which is in green, you see here. The standard is the septum here in green. And you see that this septum is much earlier than this very late lateral wall. We can also do that with real-time 3D echo. Here you see the 3D echo, and the 3D echo is giving us 16 segments, and every segment has a curve like this. And what does this curve represent? This is the time from maximum volume to minimum volume. And you see that every one of these segments is reaching the minimum volume at the same time. So the ejection is taking place at the same time. This is a perfectly synchronized heart. Here you see, and now the curves are plotted upside down. So we're looking at the top. Here you see a heart with the left bundle. So we got very early peaks, as you see here. And we got also very late peaks, as we see here in this blue. If we then apply CRT to this patient with left bundle branch block, you see that they all get their peak almost at the same time. So we can use these techniques. And from this approach, we derived the so-called systolic dysynchrony index. And we can plot that in a very nice way with a polar plot. And you see here, this is the situation before CRT, where all these curves are not reaching their peak at the same time. And specifically, this area here, the posterior wall, is becoming very late. The systolic dysynchrony index is 13.6%. The situation after CRT, my red is almost gone, and you see a completely synchronized heart with the maximum, the peak now plotted in this negative way, all at the same time. So my systolic dysynchrony index is now reduced to 1.9%. So all this dysynchrony that I have here, by applying CRT, disappears. This is a good responder. Then we moved from this echo techniques to 2D strain, and that is what everybody nowadays is looking at. So if we look at this picture here, this is a short axis, and you see all different areas of this ventricle, and they all have different colors. And from these different colors, we can get different curves. And here you see each curve for each color here. And you see that each time has the maximum 2D strain at the same time. Now I show you a completely non-synchronized heart. This heart is actually very early peak happening here. The early peak is happening here, and the late peak is happening here. So this is a completely desynchronous heart, and it shows AS to P 260 milliseconds. So that means that the septum is early and the posterior wall is very late. If I apply CRT, then I see that all the parts are now reaching their maximum at the same time. So I create synchronization. So let's go back to this prospectile. Why to predict? Well, technical issues, and we are improving. We're developing better ecosystems, and I showed you that we can just assess the dysynchrony quite well, specifically with the 2D strain, and we can also show resynchronization. But it's not just a technical story. There is also the real life, the pathophysiological issues. And there are two issues that I want to just highlight with you. One is the mismatch between the left ventricular lead and the site of the latest mechanical activation. So my lead is here, but my mechanical latest activation is there. So we are not pacing at the place where I need to be. And then you got a big issue that all these ischemic heart disease patients have scar tissue. And there was once a person who said dead meat won't beat, and that is true. If you got a big infarct, you can pace it what you want, but it will never start beating. So let's take a look at mismatch between the pacing lead and the site of latest activation, and let's take a look at scar tissue. So this is a study that we published in 2008 already. This is 244 patients, and we have 40% discordant. That means that the pacing lead is not in the site of latest activation. And we got 63% that are concordant. And that means that my pacing lead is exactly in the area where he should pace, namely the latest activation. If we look at these patients at 6 months follow-up, we see in the concordant areas where everything is taking place exactly at the time that it should. So I'm having the latest activation, my pacing lead is in there. Then I see that I improve significantly in ejection fraction. This is before pacing, this is after pacing. I make a significant improvement in ejection fraction. If my pacing lead is not in the latest activated area, I do not improve in ejection fraction. Now we look at the end diastolic volume. If my pacing lead is in the area of latest activation, I get a significant reduction in end diastolic volume, as you can see here. If it's in the discordant, as you see there in the middle, it remains completely the same. So the EDV does not change at all. And you see the same picture for the LV and systolic volume. Actually, the systolic volume also decreases if my pacing lead is in the area of the latest activation. Whereas it is not, I see no change. So if my pacing lead is in the latest activated area, I get an improvement in ejection fraction, I get a reduction in LV and diastolic volume, I get a reduction in LV and systolic volume. And this actually translated into a better survival. Here you see survival up to 48 months, 2 years. And I see that if the pacing lead is not in the right position, the mortality is significantly higher than if the pacing lead is in the right position. Still, patients die and they have heart failure. We resynchronize them, they do well, but because of the heart failure, patients will always die. But if the pacing lead is in the wrong position, we will not get it right. How can we better target our pre-target? We know before that we have venous anatomy where I can position my pacing lead. Well, we can do that with cardiac CT. And if we do cardiac CT, this is a normal heart where you see the coronary sinus and you see a big posterior venous branch. And this is what you see here also. But some patients, specifically the ones after infarction, they have only very small vessels left, and not specifically in the posterior area where most of the dysynchrony is taking place. Now let's go now to the scar tissue, and that's related to the previous one. So you lose your veins if you got big scars, but also if you got scars, as we can see on MRI, they can be non-transmural, very little, or they can be completely transmural, very big infarction. And we show here that out of the patients where the lead position is in an area of no scar, in a live tissue, viable tissue, 81% response. Whereas if I put my pacing lead in a scar on the MRI, 86% non-response. In other words, that means you can pace what you want, that ventricle, but you won't make it contract. And that also shows that if you look here at the total scar score, the more scar I have in my ventricle, the change in ejection fraction, the improvement in ejection fraction is not going to happen. The more scar tissue there is, the less improvement after CRT. I'd like to conclude that imaging of LV dysynchrony remains useful for selections of patients. If you got a lot of dysynchrony, is good. You can resynchronize that. How to do it? Which technique? Echocardiography. We need a little bit better reproducibility. We've worked on that. That got better. We also developed better techniques. If you ask me what is the best technique at the moment, I say two-dimensional strain. That is the technique where you can measure the easiest the synchronicity. But there's also pathophysiological issues, and I showed you these two. And actually, that is where the scar formation is the most important one. If you have a lot of scar, you can pace what you want, but it's not going to result in a good success. So let's go through the final slide with the algorithm. Heart failure patients eligible for CRT, less than EF35. This should be 2, so New York class 2 to 4, and a QRS over 120 to 130 milliseconds. What is my likelihood of response if I take the patients that the guideline prescribe us? I need to have a lot of dysynchrony. I need to have no scar tissue in the LV lead position. I do not want to have extensive scar, and I need to have enough veins to get it in the latest activated area. If all these are doing what I want, then I get a very high likelihood of response. However, if I got a lot of scar and I cannot get my vein in the right position, I have no dysynchrony, then it's not going to work out. This is how imaging can help you to improve your selection of patients for CRT. Again, I'm sorry that I could not be with you. I also realized that I went a little bit too long, but this is a very comprehensive lecture that can help you to better select your patient for CRT. I hope next time, next year, better times, with probably good vaccines, and your country is taking a lead on that. And I'm very impressed by how you do it and how proactive you're working on that. Hopefully next year we see each other again. Now, for now, stay healthy. I hope this lecture was of any use for you, and thank you very much. Bye.
Ну что ж, большое спасибо от нас всех профессору Ероину Баксу, большому другу и нашей страны, и нашего центра. Прекрасная иллюстрация того, что теперь мы называем эхокардиографией. Потрясающие прецизионные методы выбора стратегии терапии у больного с сердечной недостаточностью. И в целом мы завершили программу нашего сегодняшнего заседания. Мы послушали 4 доклада, которые, казалось бы, о разном, о липопротеинах низкой плотности, собственно, о выборе стратегии лечения ишемической болезни сердца, о понимании глубинных патофизиологических, даже я бы сказал, физиологических механизмов работы сердца как насоса и, наконец, методологии отбора пациентов на ресинхронизирующую терапию. Но их объединяет, как мне кажется, одно очень важное обстоятельство. Современная кардиология уже стала абсолютно точно персонализированной. Ведь каждый из этих докладов характеризовал выбор тактики и стратегии ведения пациента с разных точек зрения на основе очень точных представлений о этом пациенте, количественных представлений. Медицина по-прежнему остается искусством, это правда, но количественная оценка, характеристика состояния сердечно-сосудистой системы выходит, наверное, на первое место в определении того, как мы будем лечить пациента и какой выход от этой терапии или вмешательства мы получим. Я благодарю всех присутствующих на нашем сегодняшнем заседании, всех участников, и от вашего имени заочно благодарю наших лекторов. Спасибо вам большое. И я думаю, на этом мы заканчиваем нашу сегодняшнюю программу этого заседания. Я прошу всех тех, кто сегодня участвовал, кто подключался к нам, не оставлять нас. И сегодня очень интересный день, будет очень много симпозиумов, много докладов. И, пожалуйста, оставайтесь с нами. Спасибо.